Welcome, everybody, to the presentation of leaky pipes and analysis of the clinical pathway for better outcomes for increased continence across the lifespan. And our speakers today are Rachel Percoco from Preferred Therapy Solutions. Rachel has been a physical therapist for 20 years and a pelvic floor specialist for 19 years. Her current role is Director of Outpatient Services for Preferred Therapy Solutions. Our second speaker is Beth Huller from ACP. She's been a physical therapist for 25 years and a pelvic floor specialist for 7 years. Her current role is Regional Manager of Sales and Business Development for ACP. And our final speaker for today is Rita Cole. Rita has been a speech-language pathologist by background and has 30 plus years in direct patient care, clinical programming, and compliance management. Her current role is Director of Clinical Services with Net Health. So today we'll go over a few of our housekeeping reminders. All of our attendees are on mute. We do welcome your questions. So if you have questions throughout the presentation for our speakers, please use your Q&A button that is located on your attendee toolbar. It is a little call-out box with a question mark on it. So please use that to put any of your questions into the chat for our speakers, and we will address those at the end of the presentation. Our handouts can be found on the NARA website under the Resources tab and then Quick Links page. This is also the spot where you will find the recording and the handout for part 1 of this series. If you have technical questions, please submit those for us to review in the chat button. Again, questions for our speakers go in the Q&A box, and technical questions go into the chat box. We are recording this presentation today, and it will be available on the NARA website under Resources and Quick Links page on Monday. For our NARA members, it will be in the NARA portal under the Webinars page. We have had several questions about application of incontinence that our speakers have talked about. So we are going to be scheduling a part 3 for this series. So we will put that link for registration in the chat box, so you can go ahead and you can register for that. That one will be held on February 20th. And then I believe our speakers had a couple of questions that they wanted to ask. Beth, do you want me to go ahead and pop those polls up?
Yes, that would be great.
And our first question is, what is the most common age group that you treat? So we'll leave that open for just about 30 seconds. Our second question is, are you currently treating patients with incontinence? Our third question is, what setting are you treating incontinence? Our fourth question is, what is your greatest challenge for treatment of incontinence? And then you can check as many of those ones that apply. And then our final question is, what is the most common payer source for incontinence pelvic health services that you're treating? All right, so I'm going to go ahead and end the poll, Beth. And then, so primarily over 65. Looks like we do have some pediatrics and some younger. What setting are you treating incontinence in? We have SNF, senior living, and outpatient clinics. The greatest challenges, let's see, the most is lack of staff knowledge or confidence, and then poor outcomes due to lack of follow-through. And finally, it looks like traditional Medicare is 50%, and then followed by managed care.
All right. Thank you, Christy. Well, I'm excited to be here again. Those of you that came to the first webinar, I'm Beth Huller. I'm a PT pelvic health specialist with ACP. I'm going to start us off today and kind of build on what we started on the first day on the webinar 1. We talked about anatomy, the impact of posture on the pelvic floor muscles, the types of urinary incontinence. And today we're going to go into a little bit more of the assessment. We're going to look at coverage guidelines, distinguish treatment options for the type of incontinence, explore evidence, and then identify postural exercises as treatment, and then also look at neuromuscular e-stim and some biofeedback and other treatment options for urinary incontinence. So I'm going to start with assessment of the pelvic floor muscles. Um, Last webinar, I talked a lot about posture and the impact that your posture has on the pelvic floor muscles. The pelvic floor muscles are very important for urinary incontinence and probably the first place we all think of when we think of urinary incontinence and what is going to be in our treatment plan. There are two different ways that we can assess this or that we're going to go at the pelvic floor muscles. The first is if you are a pelvic floor trained clinician, the training is going to be a lot more in depth and your comfort level of doing internal assessments will be there. So the treatment techniques or the assessment techniques are typically biofeedback using either a vaginal or an anal probe. You can also do surface EMG, and that would be putting electrodes over areas of the pelvic floor musculature. So typically we're going to go on either side of the anus. Digital palpation is the primary method for a pelvic floor trained clinician. And this is where a gloved finger is going to go either inside the vagina or the rectum. And we're going to have the pelvic floor muscles contract around our finger. The idea behind this is we're looking at strength and we're looking at endurance. So when we are judging this or really looking at a standardized approach to measuring it, typical measurement and the most common used is the perfect scheme. It's looking at power, endurance, repetitions, fast contractions, as well as timing every single contraction. And that's where perfect comes from. So with our finger placed and having the direction of squeeze your pelvic floor muscles around my finger, sometimes we'll use, squeeze your pelvic floor muscles like you're trying to stop the flow of urine. And I do want to say that's probably the most common way that clinicians talk to patients about the pelvic floor muscles. It's a great way to identify it, helps us kind of know what we're contracting, but we do want to make sure we let our patients know don't exercise while you're urinating. We don't want our patients going and doing pelvic floor muscle contractions, stopping that flow of urine while they're urinating. That can lead to bladder retention. So if you use that, it's totally fine, very common, but make sure you give that extra directive. The first thing that we're going to do is we're going to feel how hard that contraction is. And there is a rating system that's a manual muscle test score. So we'll get our score, and then we're going to ask them to hold it as long as they can. So let's say they do a contraction that's a 3 on the manual muscle test, and they're holding it for 3 seconds. My next directive is going to be squeeze around my finger, and I want you to hold it for 3 seconds, and let's see how many you can do holding for 3 seconds. And that's looking at repetition. If they can hold, they do 5 holding for 3 seconds, and number 6, they hold for 2 seconds and then let go. Then I know that they can hold for a total of 5 for the repetitions. The next is how many times can you quickly contract? And that's important for the pelvic floor muscles because when I sneeze or I do something that has an increase of intra-abdominal pressure, I need those pelvic floor muscles to kick in quickly. And that's called your fast twitch or your quick flick. That is the perfect scheme, and it's a great way to have a standardized measurement for your pelvic floor and a great way to write goals and to see if your plan of care is working or not. The things that we're assessing in this internal pelvic floor assessment are muscle contraction, as I just mentioned. But we also want to look at, are you able to relax your pelvic floor muscles? Are you able to bulge your pelvic floor muscles? That's also very important. So we know if our patient's able to get full excursion and full range of motion of their pelvic floor musculature. We're always looking for pain assessment, checking if there's trigger points or tender spots, and then prolapse evaluation, all part of the assessment of a pelvic floor trained clinician. Now, many people are not pelvic floor trained, and they might not be comfortable doing an internal assessment, or they're not trained to do an internal assessment, or the patient doesn't want an internal assessment. So these are ways that we can assess the pelvic floor musculature for the general clinician. We can still use biofeedback, and we would do surface EMG externally around the pelvic floor musculature. You can also do surface EMG at the transverse abdominal muscle, which shares some connective tissue with the pelvic floor, and it's a synergistic muscle. So if the transverse abdominal muscle contracts, we have a good sense that the pelvic floor muscle is also contracting. But my favorite way to assess it is the coccyx motion palpation. And if you are in a place where you can do this, where you feel comfortable doing it, it's an easy test. You're going to go outside of your clothing and you position your hand over your sacrum. Your middle finger is going to go down by your coccyx. And then what you're going to do is perform a pelvic floor muscle contraction. So again, giving that directive to your patient, however you're comfortable and whatever kind of rings true with the patient. So squeeze your pelvic floor muscles. And we're going to feel if that coccyx tucks under, we know that they're performing a pelvic floor muscle contraction. You can use that perfect scheme with this as well. So again, the general clinician, we don't want to say, oh, the patient can do a pelvic floor muscle contraction or they can't. It's much more valuable to us if I say they can do a pelvic floor muscle contraction and they can hold it for 3 seconds, and they can do 5 holding for 3 seconds, and they can do 8 quick flicks. That's really good information. So I know if the plan of care I put in place is working or not. Important thing here is it helps all clinicians be able to screen for pelvic floor muscle dysfunction. Remembering that the pelvic floor muscles are very important for maintaining continence, but they're also very important for balance. They're important for stability. They're important for a sit to stand transfer. So every single therapist should be screening the pelvic floor muscles for stability and lumbopelvic function. It gives the approach that we can do not only in a skilled nursing facility, but home health, and you don't have any extra tools that you need. Using the perfect scheme, like I said, for guiding treatment. And then this non invasive approach is what we're always going to use for pediatric pelvic floor assessment. We're not going to do internal assessments for pediatric. So that finishes up kind of our assessment. That was a little bit of the carryover from day one. I'm going to pass this off to Rita Cole to discuss successful outcomes.
Thank you,
Thank you.
Beth. That's a fabulous wrap for assessment techniques. Now, before we move to treatment interventions, we wanted to come back to the outcome conversation that we introduced in our first webinar. And thinking about the poll results that we launched during that webinar, as well as the one that we just launched today, participant experience varies when it comes to pelvic health and incontinence issues. We want to take a second to emphasize that pelvic health and incontinence is not just a physical issue. They bring with them emotional and psychosocial complications, and that creates a huge barrier to the quality of life for persons experiencing these issues. Being therapists, gaining knowledge about both topics, along with your empathy that therapists tend to have in general, it puts you in a very unique position to create a substantial impact on a person's life. And in a value-based reimbursement climate, pelvic health and continence management present a very low risk opportunity for you to be able to highlight the value of therapy. We'd all like to think that it's just our amazing treatment that drives our outcomes. But in reality, that's not the case, and we know that. There's more to it. Patient outcomes and provider outcomes are dependent upon our awareness of any limitations that exist with treatment options for pelvic health and incontinence management, as well as ensuring that our medical records reflect our awareness of those limitations. Words do matter. When we use the right words, we will achieve the right results. And that starts with mastering the coverage guidelines. So the question becomes, whose guidelines do we follow? Next slide, please. With all your experience, you've felt the shift in your payer distribution in more recent years, where the amount of managed care is almost equaling the amount of traditional Medicare. However, payers tend to use the traditional Medicare guidelines as their starting point. So when we're talking about ensuring that patients receive the care that they have a right to receive as a beneficiary of any payer plan, without cost to them, as well as you ensuring your services are being reimbursed, we start with the CMS Benefit Policy Manual, and that's publication 100-02. It's the source document that indicates the requirements for therapy. It indicates very specifically that therapy documentation must show that services are reasonable as well as necessary. And there's two parts to that. First, there's skill. Services must be of such a complexity that they can only be safely and effectively provided by a clinician. And the other part to that is about services being acceptable practice for the patient's condition. That applies to both the assessment as well as to the prescription of any interventions that you as therapists would recommend for the pelvic health and continence management services. I think the key here is the phrase acceptable standards of practice. Coverage guidelines are reinforcing that as part of our responsibility to licensure, we have to remain current with evidence-based content to really know what's eligible for reimbursement per condition and per treatment. And then we have to document to that. The beauty here is the coverage guidelines tell us where to find what's considered acceptable standards of practice. So in addition to the benefit policy manual, participating in webinars like the one we did 2 weeks ago and today, next slide please, that are centered on evidence-based literature reviews and guide you to additional evidence-based resources, and of course are presented by qualified, certified, specialty certified, we should add, clinicians that are association supported. There's additional CMS resources that you should refer back to for identifying acceptable practice. So one of them is CMS's publication 100-04. It defines treatment approaches as well as the billing practices for those treatment approaches. And then the other one is Medicare's publication 100-03, and that's the National Coverage Determination Manual. It compiles decisions on a variety of different topics, but that of course are based on evidence. For pelvic health and continence management, one of them specifically is the NCD for non-implantable pelvic floor electrical stimulation. I will just say, as the speech therapist of the group, that's a lot of words to say at one time. But the NCD outlines how the non-implantable pelvic floor stimulator can be used as well as billed for certain patients. But it also includes must-dos for documentation. And I'm going to quote here. The patient's medical record must indicate that the patient receiving a non-implantable pelvic floor electrical stimulator was cognitively intact, was motivated, and had failed a documented trial of pelvic muscle exercise training. The NCD also notes that documentation should include the method of delivery. Next slide, please. In addition to those resources, LCDs or local coverage determinations and associated articles that are written by Medicare Administrative Contractors or MACs are additional resources that outline acceptable practice. Now, there's many of them, Noridian, Novitas, First Coast, many more. In preparing for today's webinar, we did review a handful of those, and the general consensus really is that most refer back to the Medicare Benefit Policy Manual for guidance. Keep in mind, though, MACs do have the autonomy to develop more stringent guidelines, and specific to pelvic health and continence management, there of course are a couple that do. NGS and CGS. They have some specific LCDs that do have some more stringent guidelines, and one of them is biofeedback. So the LCD does quote the NCD, noting that biofeedback is covered for the treatment of stress and/or urge incontinence. Of course, in cognitively impaired patients, they have also failed a documented trial of pelvic muscle exercise training over a course of 4 weeks. But the LCD also notes that additional documentation is necessary to justify biofeedback services beyond 5 to 6 visits. On top of that, the LCD requires documentation in the medical record of any formal instruction, monitoring, and follow-up for any prescribed pelvic muscle exercise and behavior modification. NGS and CGS also have an LCD for unattended electrical stimulation, and it contains a description for non-wound supervised e-stim, and it refers back to an NCD as well, but it adds that there must be documented objective or subjective improvements in the patient's pain within 6 visits. And if no improvement in the amount of pain is noted within those 6 visits, there has to be one of two things: either documented evidence that the treatment plan changed or the need for continued use of the modality. That LCD also notes that there must be documentation that clearly supports the use of electrical stimulation more than 12 visits. Also to note, while you're reviewing LCDs, that some of them will have a section called miscellaneous non-coverage, and they will add some other listed items there. I listed a few of those on the slide for you. You know, as we did review the different guidelines and the LCDs, we found in general that there seems to be a summary of 6 core components that must be clearly documented in the medical record to support reasonable and necessary services. So we're going to move along and dive into what those 6 items are. So first, there's a patient's history. As therapists, I think we tend to want to focus on a long list of diagnoses for history because that looks thorough in a medical record. And if you're using an EMR, this is the point in your documentation where you may want to click, 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 click. I caution you to not do that because unfortunately, more in this case is not better. It doesn't support the requirement for reasonable and necessary services. Now, some general information is important, but what's ideal is to identify the factors related to the referral that you just received for pelvic health and continence services, because it's that information that's going to help you make a decision about the long-term and the short-term goals that you want to establish, as well as about the treatment that you want to prescribe. Make sure that you're considering factors like UTI. Does the patient have a history? What about bladder infection? And if so, were they recent episodes? Was the patient hospitalized for these? How were those managed? Did either of those cause any falls? Does the patient have diabetes? And if so, what type? How long have they had it? And how is it being managed? How about history of hernia? Irritable bowel syndrome? What about connective tissue disorder? Is this a mom? And if so, did she have any issues during childbirth? And after childbirth, has there been a hysterectomy? Also consider the client's symptoms that brought them to you to begin with. Is there low back pain, passive soiling, constipation, bladder pain? History needs to be relevant to the outcomes that you're considering for your plan of treatment. Now, all patients present with some type of complexity, so this is another factor related to documentation that you need to keep in mind. And depending on what they are, they too will impact your outcome. You can gather them while you're observing the patient, reviewing an intake form, maybe a transfer form, while you're interviewing the patient or maybe the family member, and pretty easily can be incorporated into your history. There are things like vision, hearing, sensory issues. What about arthritic limitations that might impact treatment interventions? How about the patient's medications? Are there any side effects that would impact your decision making in terms of how you want to go with this patient? Get personal with the patient, really dig in. Ask the patient their feelings about pelvic health and incontinence. Is there embarrassment, fear, anxiety? Has there been an impact on the family? Has their social activity reduced, or even been eliminated. Consider whether or not the patient has spouses or partners, and has the incontinence caused them to now have to sleep in separate beds. Basic physical touch, even a hug, has that been impacted by incontinence? Social determinants of health, of course, have to be considered here too. Does the patient have any transportation issues that might impact their ability to come to treatment? Are there any monetary concerns about the use of continence management products? Any issues related to hygiene? Again, relevance is key to defensible outcome success. And then, of course, there's supportive diagnosis. Now, in an ideal world, a physician would have completed a medical assessment, defined the most specific ICD-10 codes, a primary, maybe some supporting, and given that to you in the referral. That would have allowed you then to be able to consider your evaluation findings and expand on any specific supporting treatment diagnoses. The problem is we don't live in the ideal world most of the time. So knowing that reasonable and necessary services must be reflected and must be showing specifically as acceptable practice for the patient's condition, the condition has to be correctly noted. I think it's important to note here that as you continue with your pelvic health and continence management programming, build a relationship with your referral sources so that you can have a comfort level going back to them to request the specificity in the diagnosis from the start, because that will have successful outcomes. So avoid using generic, unspecified diagnoses. You want to make sure that you capture details. So does the patient have urge incontinence? That would be N39.41. Does the patient have sensory issues with their incontinence? That would be N39.42. Is there post-void dribbling? That would be N39.43. Is there continuous leakage? N39.45. What about bladder retention, pelvic tilt, overactive or underactive pelvic muscles? There's a diagnosis to capture these granular issues. Specificity is critical.
So there was a question that came in about pediatric application, which we are going to cover a little bit today, but now is the time, so I might as well go over that. So pediatrics is really 0 to 18. So when we're thinking about incontinence, there's definitely a lot of the same issues in teenagers that we see with adults. But when thinking about like the younger pediatric population, like, elementary school age children, we see two primary diagnoses for the pediatric population. We see nighttime incontinence, which is really prolonged bedwetting. So when we expect a child to no longer wet the bed at night, that they've developed enough continence throughout the night, and we see a delay in that. So that's related to incontinence. That's really the primary diagnosis that we see in the younger pediatric population. The other primary diagnosis we see is constipation, and almost always prolonged bedwetting is related to a primary complication of constipation. So just a couple suggestions for that, because that is almost always how we would treat the bedwetting. Is we have to get to the root of the problem, which is typically constipation. One suggestion there is the position of the toilet. So we talked about how to urinate, you have to have your pelvic floor muscles relax. For defecation or bowel movements, those muscles have to relax as well. And when you think about children with the toilet seat, often their feet are dangling, and they really can't relax their muscles. We're not getting into kind of GI function, but it's also related to the angle of the colon and the rectum. So
one thing to consider, just if you see children who are having, or if you have a child who has constipation or, prolonged bedwetting, first try to see a pelvic floor therapist. But one very easy thing you can do is get something to position the legs so that the legs are fully supported. So a squatty potty, probably many of you are familiar with. But what that does is it just, not only does it help the legs to be supported, the pelvic floor muscles can relax, but it also changes the angle, the colorectal angle to be exact, that helps with bowel movement.
So just a couple of other documentation, treatment planning considerations to keep in mind. So prior level of function is one of the others that really require precision from a therapist when you're documenting there. Avoid terms like within normal limits, avoid within functional limits, as well as just the statement independent. It's really too generic, and it doesn't give the detail about pelvic health and incontinence issues. So you want to make sure as you're documenting this and considering this for your treatment planning, think about the patient's toileting. Think about whether or not the patient uses a device. Do they need equipment for that? Do they need any assistance? What type of issues existed prior to this new referral to you? Again, being clear about whether this is a new onset or some type of exacerbation is really key with all of your documentation as you transition to putting your findings down and then getting your treatment going. So is the patient using any continence management products? And if so, what type, and then how often, and then are there any costs involved with that? Because that certainly could be something that you relate back to your outcome. Did the patient previously experience any pelvic pain? How often and how was it managed? And then, of course, mobility and then body position. Beth talked about that quite a bit during our last webinar and the impact on continence. So that's all important to remember to include with prior level. I want to just emphasize again what I mentioned earlier about the opportunity here for all of you to really have a demonstrable impact on this person's life. So remember to probe about the patient's typical social patterns, their leisure activities, whether or not they're involved with community activities. Are they the type of person that was busy, busy, busy all day long, and now they don't want to leave home because of this continence issue? Super critical to make sure that that gets documented. The bladder irritants, how often are those being used? How often is the patient going to the bathroom? And then, of course, a person's cognition. And on this one, avoid saying fair, excellent, poor. Make sure that you think about how you're painting a picture of the person's cognitive function. So can the person converse? Can the person follow one or two step directions? How's their new learning skills? Do they have a point of cognitive overload? Because that's going to impact your outcome. So recognize that and be sure to document that as you develop your plan of treatment. Now, objective findings. With anything in life, objectivity helps to demonstrate change. So that's the same thing for pelvic health and incontinence management. Description is important. So what do I mean by that? Pelvic muscle contractions are altered. Palpation is tender. Posterior pelvic tilt is present. However, objectivity is critical. Sometimes when we're documenting results and establishing our treatment plan, we swing way too far towards function, and we forget to include the focus on the impairment itself. For pelvic health and for continence management, both are equally important for care planning. Avoid generic terms like reduced and frequently and often. So if we saw in the documentation, patient has reduced pelvic strength for the physical impairment, that's not objective. However, if you document something like patient's current level is 2-second hold 3 times as measured with coccyx motion palpation, that's objective. For function, patient changes continence products often, or they change their bed linens frequently, or now they're changing their clothing more than they ever did before. They may report it to you that way, but you want to dig in a little bit more so that you can have objective results. Patient reports changing their continence pad 3 times per morning, or they're changing their bed linens every other day, or they're having to change their clothes twice a day because of incontinence. So think about the behavior that you want to change and then objectify your documentation related to that. And along with objectivity is our final core documentation component, and that's the patient-centric reported outcomes. PROs or patient-reported outcomes, however you see them in the industry, they're strong influencers of medical necessity. The key thing with them is one size does not fit all. You want to select considering the patient's age and their gender. Consider their cognitive level because not all allow by proxy. Also consider selecting your evidence-based tool that is specific to the patient's condition. Let's take a look at a few of those that tend to be widespread in use with pelvic health and continence management. So there's a few listed there. Look at the title itself kind of gives it away. The pelvic pain and urinary frequency PUF. So that patient-reported outcome, as you can tell, is focused on chronic pelvic pain. It's a patient symptom scale, so the patient has to be a pretty good historian. If your patient's not having pain, then that's not really the one you want to look at. Consider another one, maybe the Incontinence Impact Questionnaire. This one's a 30-item self-report that's intended to measure disease-specific quality of life in women with stress urinary incontinence. So if your patient is male with urge incontinence, take this one off the list. One other one, the Quality of Life Scale, IQOL. It's a 22-item self-report, patient-reported outcome, and it's designed to assess the health-related quality of life impact of urinary incontinence, and it's ideal for 65-year-olds and older. So all of those factors matter when it comes to selecting your patient-reported outcome, and doing your homework beforehand is super critical for outcome success. Kind of as a summary, medical necessity is important for your outcomes. Again, the right words will produce your right results. I'm going to pass it back to Beth so she can dive into treatment techniques.
Thank you, Rita. And I apologize to everybody. They say the blue screen of death, and I had the black screen of death on both of my screens. And I'm sweating now because I'm panicking. But now we're talking about the fun stuff. How do we treat incontinence? There are many different ways for us to treat, a lot of different treatment options. This slide really goes over the ones that we are going to cover because these are the ones that most clinicians have access to. So lifestyle changes, pelvic floor exercises. We're going to talk about posture and the impact that your postural muscles and the exercises have on the pelvic floor, bladder training, neuromuscular e-stim, and biofeedback. And then we did just want to list out the other treatments, just so you're aware of what all of the options are out there. Most of these don't fall into the scope of practice for the physical therapist, occupational therapist, but medications, topical estrogen, Botox, posterior tibial nerve stim is in the literature a lot. And this is looking at a thin needle that is placed into the ankle, into the posterior tib nerve. There is a lot of research showing surface e-stim over the posterior tib nerve can also be effective. And just as a kind of FYI, and this is a course well beyond what we're going to cover, but looking at the neuroanatomy of bladder filling and bladder emptying, it's T10 through L2 and S2, 3, and 4. Posterior tib is your sacral nerve roots. So that's why that works. It's a very cool treatment. We're not going to dive deep into it today. And then surgery, medical devices, and magnesium. So first to start, the pelvic floor muscles, and we talked a lot about them last webinar and the assessment of them today, very important when we're looking at maintaining continence. It is shown by multiple researchers to decrease the number of episodes of stress UI. So we are going to look at the pelvic floor muscles, but I do want to make sure we're taking that outside in approach and look at those postural muscles today as well. This is just research that really supports the pelvic floor muscles. So, a Cochrane review, which is a high level of research of 31 studies, concluded that pelvic floor muscle training had a strong correlation to improvement or even a cure of stress urinary incontinence. Next slide. And then this is evidence supporting just general exercise for urinary incontinence. And this is really the whole idea of the outside in. So, just to look at a couple of these, the first one looking at lumbar stabilization exercises. And we know, because we've reviewed the anatomy, a big part of that is the impact it has on the positioning of your pelvic floor muscles and the functioning of your pelvic floor muscles. Yoga has a high correlation of treatment with UI. Even the ankle has been looked at. And then looking at hip rotation for stress urinary incontinence. So, this I just hope supports that idea for you of outside in, and then remembering the body is a demand system. So, muscles will shorten to the length of the most common position held. So, if I'm sitting at my desk all day and I'm sitting in a kyphotic positioning, that's going to become my position down the road because we actually shorten our muscles in the number of sarcomeres. Your muscles are going to weaken if they're not used or stressed. Your bones are going to weaken if they're inadequately loaded. So, really looking at neural arthrogenic muscular changes as they kind of reduce as we age. Everybody at this point has probably heard of sarcopenia. So, we know in our 60s and 70s we have about a 70% muscle mass loss. 80s and 90s, it's about an 80% muscle mass loss. We know that this is happening as we age. It's happening to our pelvic floor muscles as well. And then bed rest, the effect that that has. Next. As we get into some of the treatments and really just looking at the muscles that we need to be focusing on, always remembering exercise principles. This is an important piece as therapists when we're writing out our plan of care, when we're billing therapeutic exercise. We need to make sure that our treatment and our plan of care has overload and progression. If we're not increasing the demand, we're not gaining strength. There needs to be specificity. So, are you working on slow or fast muscle twitch? Or is it voluntary or involuntary? Always thinking about length and tension. Again, this is the entire discussion of pelvic floor muscles. If my body and my posture is in a abnormal positioning, the length and tension on my pelvic floor muscles is also abnormal. Reversibility, so gains are lost if exercise level is not maintained. And then periodization, must change or progress exercise or activity to continue to make gains. Next. Next. So we're going to start with, this is a list, and I'm not going to go in detail on all of these things. Primarily, we don't have time. It's even more limited because of my snafu. But we're doing these exercises. Most therapists are doing these exercises. The idea with this now is looking at it and the impact that it has on your pelvic floor. So when we're looking at incontinence, and we first want to start pelvic floor relaxing it. We can't do anything. If our pelvic floor is like this and tight up, we're not going to get any movement in our lumbar. We're going to be restricted because of pelvic floor restriction. So looking at down training the pelvic floor is a key first step. Then we're going to move into lumbar range of motion in multiple positions and planes is important. We are going to take a look at an exercise that I highly recommend therapists start to add to your plan of care. But abdominal strengthening, we're already doing. So looking at it, multiple positions, multiple planes, spinal extension, multiple positions and planes, gluteal exercise, hamstring stretch, hip flexor, hip rotation, diaphragmatic breathing, which we are going to look a little closer at today because I don't know it's added into the plan of care as frequently as it should or could be. And then looking at your pelvic floor muscle strengthening or that up training and doing Kegels. So the first one, this is the one that I love, pelvic clock. So we're looking at lumbar range of motion and pelvic movement. So if you are in a place that you feel comfortable doing it, please do it along with me. You imagine that you have a clock on top of your pubic bone, so over your pelvis. 12 o'clock is pointed toward your head, 6 o'clock at your feet. If I'm a therapist working with a patient, I'm taking my hands and putting them on my patient's hips. I want to feel what this movement feels like. You can do it in seated, supine, standing, but I'm taking that patient from 12 o'clock, which is a posterior pelvic tilt, to 6 o'clock, which is an anterior pelvic tilt. And it can be passive range of motion to start. Great way. If they don't know what you're talking about, great way to get them moving. Active assistive range of motion to active. I did see a lot of people are treating geriatric patients. Think about your geriatric patient and what is happening at their pelvis. They're not getting a whole lot of movement at their pelvis as we age. If they're using a walker, it's even less because arm swing helps with some pelvis rotation and movement. So think about how much that pelvis is staying in one position and then how difficult it is sometimes to get them from a sit to stand and go to their pelvis. Their pelvis, majority of the time, is not moving from this 6 to 12. So that's your first step. The next is take them around the whole clock. So now you're going to go from 12 to 3 to 6 to 9. And it's like a hula hoop. So hula hoop is a great way to explain it. Most patients, most people have hula hooped or seen somebody hula hoop in their life. So even just sitting there, you can go through this movement. And as the therapist, you're holding their hips and you're feeling if there's anywhere that feels tight, restricted, locked up, that's going to lead you back to that list we just looked at. Where do I need to focus my attention? Either strengthening it or stretching it. You also want to make sure that it's pain-free range of motion. Next slide. So outside that list we looked at, going inside, we've talked about the pelvic floor muscles a good bit. We mentioned the diaphragm, but this is really your core. This is the innermost core of our bodies. And it's really the most important thing from a stability standpoint to strengthen, because everything else is not going to have as much stability without these muscles. So the diaphragm, transverse abdominis, multifidus, and pelvic floor muscles. And we'll look at these together. But if you look at those pictures, diaphragm superior, your pelvic floor muscles inferior, multifidus or posterior, transverse abdominal muscles, your most inferior or your deepest anterior musculature. Next. So diaphragmatic breathing, again, multiple planes, and we want to do it in different body positions. So multiple planes, if there's one thing that you get from everything that I've said, it's really making sure we're looking at all of these movements in different ways, in different planes. We don't want to assess a patient in one plane seated in a wheelchair or standing or on a mat. Make sure we're assessing from all different positions. Diaphragmatic breathing is highly recommended. Again, it's the superior portion. If you picture a patient right now, and again, focusing on that geriatric, but all of our patients, think about how they breathe. We're all guilty of this. We learn over time how not to breathe wrong, really. If you picture a baby and you lay a baby down, their stomach goes up as they're breathing. We learn not to do that. It's not super attractive for your stomach to be going in and out through the day. It's also not really comfortable if you have on tighter clothes, but we need to be having diaphragmatic breathing for proper excursion and range of motion of the diaphragm. You can add weights to that or add bands to this to give some resistance, or you can purchase different devices for resistance. Even closing off one nostril can create resistance for diaphragmatic breathing. Next. Multifidus is a crucial muscle when we're looking at stabilization of the spine. Extension, rotation, lateral flexion. This is your bird dog. You can do this position. You can do it with an exercise ball. You can do it without an exercise ball. It is a great exercise for every patient population to strengthen the multifidus. Next. Transverse abdominal muscle, I mentioned already its unique relationship with the pelvic floor muscles. They have a synergistic relationship. Again, if you're in a comfortable place, you can put your hands just inside of your ASIS and towards your pubic area and feel for your feel for your transverse abdominal muscle and do a pelvic floor contraction. So do a Kegel and you'll feel that transverse abdominal muscle tighten up or tuck in. This is an important muscle to exercise specifically for those that might be having trouble finding their pelvic floor muscles. And this just kind of walks you through an example. But again, different planes, different positions. Next. I mentioned relaxation of the pelvic floor. These 4 pictures are really my favorite exercises for relaxing it. So the goal here is to decrease tone in the pelvic floor. I think we used the example last webinar. If your pelvic floor muscles are, tight, like my traps, your treatment plan for me is not going to be go and do some shoulder shrugs. So you don't want to send home a patient with tight pelvic floor, go do Kegels, because there's nothing happening. Your first goal is down train, and now we can start to strengthen. And these exercises are great ways to do that. Biofeedback is a great way to see where their tone is at and to give you objective data. Next. And then we can move into up training or Kegels. So we want to just get pelvic floor muscle contractions. And we talked about a couple of different ways to get your patient to do that. Next slide, we'll talk about what the dosing is. So we want to make sure we're progressing the patient. We want to increase to 10 seconds. You're going to use your initial assessment to decide where you start. If they held for 2 seconds, that's where you're going to start, and you're going to work up to 10 seconds. Gradually increase velocity, eccentric contractions, and then changing position. Next. Fast twitch firing, this is used to decrease urgency. So you can actually use really fast pelvic floor muscle contractions to relax the bladder or the detrusor. This is a great technique to use when we get into some urge incontinence. The idea here is the neuroanatomy again, and the way that works. T10 through L2 fires when S2, 3, and 4 are relaxed. When S2, 3, and 4 fire, then they can get the firing at T10 through L2. Next.
Okay, so we have, because these next few treatment slides are really quite important, we're going to look at E-stim, biofeedback, and bladder training. And for the non-pelvic floor clinician, bladder training is really, really important. So we want to save time for that. So on day 3, which is February 20th, we will go right back here. We'll look at these final treatment options. And then we're going to look at a case study, which is going to be really fun. So we have a gentleman, and he has mixed incontinence, which means he has both stress and urge. The reason why we gave him mixed incontinence is because it's going to give us an opportunity to look at all of the treatment options to treat both types of incontinence. And we're going to start with him younger, kind of living in a different place and with a different cognitive capacity. And then we're going to age him and make his symptoms a bit more severe. And now he's going to be residing in a skilled nursing facility. So it's going to give us the opportunity to look at how we would manage these symptoms in somebody living in a different place, having a different cognitive level and ability to learn new information versus maybe not, and how can we support them there. So it's going to be very fun. So we hope you'll join us for day 3. Let's just see if any questions.
And I am looking in the chat. I don't see any questions. If there's any questions, please put them in the chat. Appreciate everybody coming. And again, I'm going to offer my apologies again for my black screens.
Thank you so much, ladies. It looks like we just had a question pop up in the chat. Which standardized assessments are validated for male patients?
So how about if we take that and include the answer into our case example on our next session?
And it looks like we're just over our time. So thank you everybody so much for participating, and look for that registration link. We did put it in the chat, so hopefully you caught that. We will also add it to our website so that you can make sure you get registered for part 3.